Hello, everybody. We'll just give this about 30 seconds or so to get everybody in before we get started with Dr. Rubin. We need some music or something. Next year we'll do music with this part.
I could sing. I could tell jokes.
Yeah.
That survey will come back up after this session too, if they weren't able to fill it out last time.
Okay.
Go ahead and get started, Deb.
Okay. Well, now that we've got a good amount in the room, I'd like to take this time to introduce Dr. Rubin. She's from Columbia University, and she will speak to us about skeletal disease. So Dr. Rubin, the floor is yours.
Thank you so much. Good afternoon, everybody. And it's a pleasure and an honor for me to be here today. These are my disclosures. So just a brief mention of the history of the parathyroid gland, which is actually the most recently discovered organ in the human body. It was identified in a rhinoceros first in 1850, and then a Swedish medical student drew it out, as we see in this diagram here. Nobody really had any interest in it, but he did manage to publish it in a local journal. And nobody thought much about it until 1925, when it was realized that the extract of the parathyroid could rescue tetany. And then eventually it was synthesized and the receptor was cloned. And we're still part of the unfolding history of parathyroid disease and use of parathyroid hormone today. So as we all know, the biochemical hallmark of hypoparathyroidism is low calcium with an inappropriately low or normal PTH level. And I'm just very briefly mentioning here the pathophysiology, which leads to the low serum calcium. As we know, normally PTH acts at the kidney in order to reabsorb calcium that's been filtered, but that doesn't happen in the absence of PTH. So hypocalcemia and hypercalciuria ensue. We also need PTH to stimulate the 1-alpha hydroxylase, which converts the inactive 25-hydroxyvitamin D to the activated 1,25-dihydroxyvitamin D to lead to absorption of calcium in the intestine. And in the absence of PTH, that won't happen, so we don't get enough GI absorption. And finally, usually PTH will stimulate bone resorption and liberate calcium from bone to go into the bloodstream. And that is not going to happen in the absence of PTH either. So these pathways altogether lead to a low serum calcium. And we know the symptoms well, which are dominated by neuromuscular irritability with the numbness, paresthesias, muscle spasms, and neurocognitive difficulties. And of course, we know the more serious and dangerous complications. So with that brief overview of hypoparathyroidism in general, I'm going to turn now to focus on the bone. And first, I'm going to talk about bone in hypoparathyroidism when there isn't any PTH around. And this was our original cohort, which we recruited years ago. And I even wonder if some of the participants are in the audience here today. And it was a cohort that was very representative of hypoparathyroidism. There were more women than men, as we know is typical for the disease. Our group was actually split between surgical and non-surgical patients, even though we know that most adult patients are surgical patients. The amounts of calcitriol that the patients were taking were pretty typical, 0.75 micrograms a day on average, and about 2.5 grams of calcium a day on average. And the biochemistries were pretty typical also, with a low normal serum calcium, lower undetectable PTH, and a phosphate that was in the upper limit of the normal range. So the first thing that I'm going to show you is what bone density looked like. And this has been observed not only by us, but by other investigators as well, which is that the bone density is increased. So it's increased at all sites in the skeleton, but it seems to even be particularly increased at the lumbar spine. And this number here on the y-axis, the Z-score, is how the bone density compares to other people who are the same age and the same sex. So you could see that it's really higher at every site, and especially so at the spine. So it's a thicker bone. And we went on to look at this more closely with a more sensitive tool than regular bone density, which is to use high resolution imaging. The full name of this tool is high resolution peripheral quantitative computed tomography. And what it does is it takes pictures that are slices both at the wrist and at the ankle. And this is very powerful because it can give us a three-dimensional picture of the bone. The regular bone density is just a two-dimensional picture. And it can also separate out the inner part of the bone, which is this trabecular compartment here, which looks more like a honeycomb or a Swiss cheese, as opposed to the cortical, which is the outer part here, which is more of a solid structure. And we could get microscopic detail of the bone, almost as if we were doing a bone biopsy, to see exactly what's going on in terms of changes in these two compartments, trabecular and cortical, of the bone. So my colleague, Natalie Cusano, looked at this, and what she found was that there was just more bone, both in the trabecular compartment and in the cortical compartment. So the number of the trabeculae, which are like these little microscopic struts, was increased. They were less separated, so that means they were more packed together because there was more of them. And in the cortical solid part of the bone, there was a greater volume of the bone density. And cortical bone normally has little holes in it, but there was a decrease in the amount of these holes. Again, consistent with this theme of there being a thicker, denser bone overall. However, with the images, you can simulate how strong the bone is, what happens if you try to crush it in the models. And we saw that there was no difference in the bone strength despite these changes. Another study, not from our group, looked at only non-surgical patients using this same tool of high resolution imaging and found a very similar thing, more trabecular bone and more cortical bone. So this idea of there being thicker bone that's present. We then looked at this more directly with bone biopsies so that we could examine the bone itself under the microscope. And here, simply seeing a picture of what the bone looked like, you can just eyeball it and see that the bone from a hypoparathyroid person is thicker, both in terms of this inner trabecular kind of Swiss cheese part and the outer solid cortical part. And we were able to quantify these specific measures. So the yellow is the hypoparathyroid group. The cortical bone was thicker. The yellow again is the hypoparathyroid, and the cancellus, which is another word for trabecular, that bone was also thicker. Each individual trabeculae was wider or thicker. And then we went on to take three-dimensional pictures of the bone. And this is what trabecular bone usually looks like in a 3D picture. Again, it looks normally like it has a honeycomb or Swiss cheese structure. But when we looked at the same trabecular site in a hypoparathyroid patient, you could see that the Swiss cheese shape is almost getting lost because the bone is becoming thick and dense, that it's almost like it's becoming solid. And again, we were able to measure this out, specifically showing that the bone volume was greater in the trabecular bone. There were thicker trabeculae, there was a greater number, and they were less separated because they were more packed together. And we were also able to measure whether there were thick plates or skinny rods. And thick plates are usually something that we look for because the rods that are skinny are what we see in osteoporosis. So we usually want to see more thick and plate-like bone, but here it was almost off the chart. The bone was so thick and almost overly plate-like. And by measuring the connectivity of the little trabecular struts, we saw that they were very highly connected. So taken together, this shows that the bone is very thick and very dense at every level, the trabecular level and the cortical level. So why is that? Why is that happening? Well, it's really thought to be because bone turnover is low. And we looked at this in the bone biopsies. And what we did was our patients who were willing to undergo the bone biopsy of the hip, of the iliac crest, we asked them to take an antibiotic beforehand, not because they were going to get an infection, but because this antibiotic called tetracycline fluoresces or lights up in the bone. And we asked the patients to take it for 3 days, then not to take it at all for 5 days, and then take it again for 3 days. And what this does is it creates 2 lines in the bone, and it's a little bit like rings in a tree. So you can measure what happened in those 5 days between the first rounds of the antibiotic and the last round of the antibiotic and see, is the bone growing normally? Is it replacing itself normally? because healthy bone is constantly replacing itself and repairing itself every day. And we found in the hypoparathyroid patients that this label from the antibiotic was hardly being taken up. And this is consistent with the bone turnover state being very low, or in other words, a situation of low bone remodeling. And we were able to quantify this again, showing that the surface that was building up new mineral was low in the hypoparathyroid patients, as seen here in the yellow. The rate that it was building up was low, and the new bone that was forming was low. So altogether showing a profoundly suppressed state of bone turnover. So what does this mean? I've told you that the structure or the shape of the bone is very thickened and there's extra bone, that the bone replacement is very slow. But the third aspect is that this might lead to abnormal material in the bone. So what the bone is actually made up of. And bone is made up of two different components. There's the mineral part of the bone, like the calcium, the phosphate, the hydroxyapatite. And there's also the collagen part of the bone. It's also called the organic matrix. That's the collagen scaffolding that the mineral will attach itself to. And we examined both of these, the mineral and the collagen matrix, to see how they were affected in hypoparathyroidism. And we looked at the mineral using a tool that could measure how dense the mineral is. And it basically is done by looking at how gray these electron imagings are. And you can calculate from that just how dense the distribution of the mineral is. And there's a very tight normal range, and that's in this gray shaded area here. And it actually holds very constant, even for different ages, for women and men. And what we found in our hypoparathyroid patients is that this curve was shifted to the right, the black dotted line. And this is consistent with there being a higher bone mineral density distribution. And if you think about it, it makes sense because everything is slowed down in the bone. So the normal bone replacement is slowed down. So mineral is going to accumulate more just because there's more time for it to accumulate. And that can lead to this hypermineralized bone. We also looked at the collagen maturity. And for this, if collagen is young, in this test, it's a green color. And if collagen is old or mature, it's a yellow color. And we found that in our hypoparathyroid patients, there was an excess of this yellow color resulting, consistent with the collagen being hyper mature. And again, this makes perfect sense because with the low bone turnover, the collagen is going to be much slower at replacing itself. So the material properties together show that the bone is very mineralized and that the collagen is hyper mature. And we looked at these material properties one more way by doing a test called microindentation. And this is a picture of me doing it. And I used a handheld tool which indents a tiny needle only as thick as a hair into the bone, but the needle can sense how deep the bone is allowing it to sink in. And if the bone permits the needle to sink more deeply, that means that the material of the bone is weaker because it should really be resisting the sinking in of the needle. And we found that in hypoparathyroid patients, the needle was able to sink in a little bit farther, 11% more than in non-hypoparathyroid patients, suggesting that maybe the bone material is weaker, even though the bone density is unusually high, and even though the bone is thicker, that maybe the material is weaker, as seen by allowing this probe to sink a little more into the bone. Although I have to say that there is still uncertainty about just how clinically meaningful this test is. So a little bit to take this data with a grain of salt. And now I'm going to talk about probably the most important part of the talk, which is, so are people with hypoparathyroidism more vulnerable to having a fracture? What does this mean, aside from all of this data with images and biopsies? And the best data that we have come from the Danish registry studies from Dr. Reinmark, where they showed in both post-surgical and non-surgical hypoparathyroid patients that there was, in fact, no difference in overall fracture risk. So that's actually enormously reassuring to hear that these findings that we saw in bone using all these different tools probably don't seem to translate to actually having more fractures. They did show that if you looked specifically at the type of fractures, that the non-surgical patients did have an increase in having upper extremity fractures. And actually, it's not written here, but the post-surgical patients had a slight decrease in the risk of having upper extremity fractures. So why it might be, maybe people with non-surgical hypoparathyroidism have been living for it longer. So maybe in this one specific area of the arm, there's an increased risk. But still, nevertheless, it's very reassuring that overall there isn't an increase in fracture risk. Now, there are other small studies that might suggest otherwise, and this was a study in 50 postmenopausal women, only post-surgical hypoparathyroid patients, and it did show that using a test called vertebral fracture analysis, which is a way of really almost getting like an X-ray of the spine while a patient is having their bone density, that there was an increase in vertebral fractures in the hypoparathyroid patients as compared to the controls. I've circled, for example, the two here. In this patient, you could see that instead of kind of the nice square shape of the vertebrae, they look a little bit squished down here. And these were patients who did not have any symptoms of a vertebral fracture, although most of the time people don't have symptoms when they have a vertebral fracture. And similar findings in another study, these were only non-surgical patients, but also an increased rate of vertebral fractures was found in these patients, and particularly so in the patients who were postmenopausal. There were men in this study also, and in patients who were taking anti-seizure medicines, because we know that anti-seizure medicines can have a harmful effect on bones. So these smaller studies might suggest that maybe we do need to be concerned about an increase in fractures. This was one report that tried to pool together all of the 7 good quality studies that looked at fractures in hypoparathyroid patients, and pooled together that led to a compilation of data from 1,470 hypoparathyroid patients. And what they found was that there was a 2-fold increased risk of having a vertebral fracture in people who had non-surgical hypoparathyroidism. It wasn't the case for people at post-surgical hypoparathyroidism, and there wasn't any increased risk for any other types of fractures like hip or arm, but just at the spine in the non-surgical patients, there was this suggestion of there being an increased risk. So I think, there really aren't enough data to say for sure, and I think I would still rely the most on the reassuring Danish data. But I think this does raise the point that the increased bone mass that we see in hypoparathyroidism does not completely assure us that it leads to increased bone strength the same way we would think about that being the case in a patient with osteoporosis. Again, why might non-surgical patients perhaps be more vulnerable? Not only because there's been a longer disease duration, but maybe these patients developed the disease before they were going through their peak bone mass accrual, which is in childhood and adolescence when people are building up the stores of bone that are going to last them for the rest of their life. Why maybe is the trabecular bone more affected? That's a type of bone that's more active and usually has more bone turnover. So maybe if bone turnover is being suppressed, the trabecular bone is being more harmed than the cortical bone, which doesn't normally have as much bone turnover to begin with. These are just speculative ideas. So I'm just going to summarize what the bone looks like in hypoparathyroidism. There's an increase in bone density. There's more trabecular and cortical bone, the 2 types of bone by imaging and bone biopsy. The bone turnover or remodeling rate is low. The bone is hypermineralized and has hypermature collagen. Perhaps there's an increased resistance, less of a resistance to having microfracture. And most important of all, fracture data are really limited. We really lack natural history information about this. There is a systematic review that's going to be published along with the upcoming guidelines that you've heard about. And there, when all the complications of hypoparathyroidism were searched for in the literature, fractures did not come up as a complication. And along those lines, bone mineral density monitoring is not included in the upcoming guidelines. So I think, based on what we know now, a fracture is not really something that we need to feel scared or think of as a high priority to worry about in this disease. But I think really it's something that it needs more data and more research. And now I'm just going to talk about how parathyroid hormone can affect some of these bone parameters. So, of course, we all know that hypoparathyroidism was the last endocrine deficiency disease to have the missing hormone replaced. And this is just something I stumbled across when I was thinking about this talk. It's actually a case from 1909 where a Canadian pathologist describes a girl who was rendered hypoparathyroid after having her thyroid removed, and she went immediately into severe tetany. And they kind of, I guess, in a desperate measure, injected some parathyroid gland mixture from a cow. And several hours later, the tetany resolved and she woke up feeling quite well. So this, I think, was the first glimmerings of hope that we could replace the hormone that was missing with relief for patients. So back to our study, we treated 64 hypoparathyroid patients back starting in around 2004 with PTH 1 to 84, and we only had it back then available as 100 micrograms. We did it every other day. So I'm going to briefly just show you what were the changes in bone that we saw with giving the hormone. So at the 2-year time point, we saw that bone increased at the spine, pretty much stayed the same at the hip, and decreased a little bit at the wrist, looking at bone density. And we tracked this out to 8 years. And this pattern pretty much held true, that there was more bone at the spine. This kind of peaked at about 4 years, but still at 8 years was higher than at baseline. Also an increase in bone density at the hip, the same at the femoral neck part of the hip. And the wrists had a decrease in bone density. But even though there's a decrease, the actual measure of the bone density was still higher than age and sex matched controls. So it decreased, but it wasn't a decrease at anything to near the osteoporosis range. When we looked at this more closely with the high resolution imaging, we saw that indeed the bone was getting thinner. The cortical bone was decreasing and little holes in the cortical bone known as cortical porosity were increasing. And the failure load, or a way to measure the bone strength, actually decreased, but it still remained above the normal level. So the bone was getting thinner. And I think this is really the question that we need to think about with PTH treatment, which is that, is it a good thing that the bone is getting thinner? And I think it probably is. If it was a patient with osteoporosis, we would be very alarmed to see the bone becoming thinner or less dense. But I think with a patient who has hypoparathyroidism, this is probably what we want to happen. And we looked at this in a lot of detail in our bone biopsy studies. We saw that at 1 year, the trabeculae were starting to get thinner. So these thicker trabeculae almost were splitting into more numerous thinner trabeculae. The cortical bone also seemed to start to get thinner, not at 1 year, but out to 2 years. And here we saw, directly examining the bone, that the holes in the bone and the cortical porosity started to increase. And this is just a picture can help explain it better. Here's what the trabecular cancellous bone looked like before PTH treatment. And you could see there are these thickened spicules or trabeculae, but osteoclasts or bone chewing cells are drilling in and are splitting what was once one fat trabeculae into 2 skinnier trabeculae. So you're getting more numerous trabeculae, but they're thinner. And the same kind of thing is happening in the more solid cortical bone, where again, the bone chewer osteoclasts are drilling in and creating more cortical pores. And again, normally we would think this is bad if we were thinking in an osteoporosis paradigm, but that very well might not be the case with hypoparathyroidism. And this is just showing carried out to 8 years. This all leads to an increase in trabecular bone volume, probably because there's just more thinner trabeculae there. The trabecular number is increasing, and overall the cortical porosity is increasing. So the bone is very activated, and this is continuing even out to 8 years and leading to these changes in the structure. To show you in the pictures what's happening in someone with normal parathyroid function, this is what a slice of bone might look like. In someone who's hypoparathyroid and doesn't have PTH, you could see the cortical section is thicker and these trabecular spicules are fatter. But then when we give PTH treatment, you could see there's more holes developing. There's an increase in the cortical porosity. There's more of what's called the osteoid surface. That's when new young collagen is being laid down. So the bone is waking up. And there's an increase in the eroded surface. That's older bone that's being removed. And we saw this reflected in a special type of bone biopsy that we did, which is even at 3 months, this bone biopsy captured changes very early on. We could see that the bone turnover already was picking up right away. This is how low the bone turnover was at baseline without PTH treatment. At 3 months, you could see it's dramatically increasing. It still was increased at 1 year, still at 2 years, although not as much. We think 1 year is the peak of the increase. And we see this in the turnover markers. This is blood tests that show bone building, the osteoblast P1NP, and bone resorption, the osteoclast or chewing CTX. Basically, everything wakes up very dramatically, but the peak seems to be at about 1 year. And then all this activation seems to kind of slow down and fall off, but not go back to as low as it was in the beginning. So here's the bone building marker for the osteoblast P1NP shooting up at 1 year and then kind of starting to come back down, but not falling to the abnormally low levels that it was before PTH treatment. And a similar pattern with the bone resorption marker CTX for the bone chewing cells. So this is suggesting that the skeleton really wakes up very dramatically at first and then kind of re-equilibrates to a normal, more healthy, what we would say euparathroid level. And the same pattern was seen in the extension of the REPLACE study, which was the study that led to FDA approval of Natpara, where the bone turnover markers shot up early on, peaking at 1 year, and then fell a little bit, but still remains in the normal range, which is what these gray shaded areas are for as long as 5 years. So they go up, peak at 12 months, and then kind of decline, but stay higher than they were at baseline. And the bone biopsy showed this same pattern, that the mineralizing surface, the bone formation, the new bone being laid down really increased. But here in the biopsies, it's a little bit different because we're seeing that the high levels of all the skeletal activation are persisting out to 8 years. So this is showing that the skeleton is still very stimulated after 8 years of treatment. And this in turn leads to the mineralization level decreasing. So where I showed you before, this dotted line showed that the bone was hypermineralized. With PTH treatment, it shifts to the left and becomes less mineralized. And this completely makes sense because new younger bone is being laid down with PTH treatment, but hasn't had time to fully mineralize yet. And actually, the mineralization level fell in the first year of treatment with the bone waking up and new bone being laid down. But out at 2 years, the mineralization level started to increase just as we would want it to. So to summarize what happens to bone with PTH treatment is that the cancellous bone volume goes up. So there's more trabecular bone because they're splitting from one thick trabeculae into more numerous skinny ones. The little holes in the cortical bone, cortical porosity increase. The remodeling rate or the bone turnover increases, and there's a transient drop in the mineralization, which then goes up. So what this is showing is that the skeleton is waking up and basically thinning down, really. And I think it's not perfect. I think what we would ideally want is the skeleton to wake up, but we don't want to overshoot it. And I wonder with Natpara, because it was a once-a-day intermittent bolus injection of PTH, did it overly stimulate the skeleton? And I think really the holy grail that we want is for there to be a continuous PTH exposure. And Dr. Karen Weiner showed this in a pilot study, which you all, I'm sure, just heard about from Dr. Mondstadt, where she gave PTH in a continuous infusion with an insulin pump. And what was very important was that the biochemistries normalized and the urinary calcium came down. But what she also showed was that the bone turnover rose just to the right level. And that's probably because this is a physiologic exposure, not like, a big burst of PTH that then tapers down, which I think maybe leads to an excessive skeletal stimulation, but rather this continuous exposure of the skeleton to PTH, I think might not only normalize biochemistries, but also the skeletal level of bone turnover. And this is very much the concept behind the TransCon PTH, where it's yielding a steady state level of PTH in the bone so that there's a continuous exposure. And we're only gathering now the information about TransCon PTH on bone, but what we do see is that the bone turnover markers shoot up pretty quickly. This is, again, the osteoblast bone formation P1NP marker, and you could see it's risen up dramatically at 12 weeks. Same thing with the bone resorption osteoclast marker, risen up dramatically at 12 weeks, which show that the skeleton is waking up, if you will. And then the data that were just presented at the American Society of Bone and Mineral Research meeting just a week or so ago show that at week 60, the bone turnover levels start to gradually drift down. So they're still much higher than the very low levels they were at baseline, but probably this robust wake up of the skeleton is drifting now into a normal euparathroid range. The bone density data are still being collected, and the TransCon PTH does seem to show that there are decreases in bone density, but the decreases are still yielding numbers that are above the normal range. So I think it's showing that the skeleton is coming down from being this overly thick, dense skeleton down into a more normal range. And I do not think that the threat of osteoporosis or excessive bone being lost is actually something that is occurring. And so lastly, I just want to mention two brief thoughts, if that's okay, which are just other cell types that might be related to what PTH does to bone. And this is this idea that PTH might be working together with its effects on bone to increase lipid breakdown. And this is just something, you know, very intriguing that I think we don't know so much about, but I heard about it at the American Society of Bone and Mineral Research meeting. So I'm bringing it up now. And there are some data that show that fat cells, when they get treated with PTH, the fat breaks down and free fatty acids are released. And the data that were presented at the recent meeting showed that when you give mice PTH, free fatty acids are released. In other words, fat is being broken down both in the bone and in fat tissue. And the thought is that the reason PTH is doing that is to actually provide nutrition or fuel for the osteoblast building cells to do their bone building. And I did find this very old study where they looked at this in hypoparathyroid patients as well as euparathyroid and pseudohypoparathyroid patients. And they actually gave these patients PTH and showed that within 45 minutes of giving them PTH, there was a breakdown of fat in the fat tissue. So I think it's just really fascinating because PTH has so many effects, and maybe it perhaps does work when we take it to break down fat, maybe to provide energy to the bone. And then the last other different idea of PTH effects related to bone that I wanted to mention was something related to immune function, where it's recently been shown that in mice, giving PTH along with a fatty acid that our gut microbiome makes together, they increase osteoblast activity, which you would expect from PTH to stimulate bone formation, but also really fascinating, together they increase the activity of immune T cells that are in the bone. So this is suggesting that one effect of PTH might be, together with this gut normal healthy bacteria, to stimulate the expansion of our immune cells. And maybe we need normal PTH levels for normal immune function, which is really interesting because one of the complications that is cited in the literature with hypoparathyroidism is an increased risk of infection. So I think, you know, these two ideas that I'm mentioning emphasize that the effects of PTH are also related to and are codependent on other pathways in other multiple cell types. So I think we could conclude that PTH certainly stimulates the hypoparathyroid skeleton. It's really kind of the opposite of the paradigm that we think about from PTH treatment with osteoporosis, where here with hypoparathyroidism, perhaps we want a thinner, less dense skeleton. fracture data are lacking. You know, I presented what we know about fractures in patients who are hypoparathyroid. We really don't know anything at all about fractures in hypoparathyroid patients who are treated with PTH. And I do think that continuous exposure of the skeleton to PTH probably would lead to a more physiologic balance of skeletal properties. So with that, I'm going to conclude and thank all the people I work with and all of my funding sources. And I'm happy now to answer any questions.
Oh, we're on mute. Thank you so much, Dr. Rubin. That was amazing. And we do have questions for you. Number one, how often do you recommend getting a DEXA scan?
So, you know, it's not in the guidelines, and I think it really probably depends on the patient. What I would probably do is follow what the guideline would be for a person who does not have hypoparathyroidism. So if it's a postmenopausal woman for whom you would want to be checking a screening bone density at menopause, and then if she doesn't fall into any additional risk categories, maybe 5 years after that. If there are other risk categories, you know, the same way we think about in non-hypoparathyroid patients, I would do it more often, maybe every 2 years, or if I was very concerned, every 1 year. You know, I do think that hypoparathyroid patients are protected from low bone densities, and there are data that show that postmenopausal women are protected. So I think you'd have to look at your individual patient, but I wouldn't automatically say that everybody needs it.
Thank you.
I got a question from Hassan in I believe Bahrain, and he's asking, what is the probability of getting osteosarcoma with taking Forteo?
Okay, so that's a very important question. I think it's known that all PTH molecules, when given to rats, have the risk of causing osteosarcoma. But I think we can feel very reassured that there is very little or probably no clinical relevance of that. The rat skeleton is not at all like the human skeleton. It's constantly remodeling. The doses given to the rats are 75 times higher than the doses given to people. And most reassuringly, there's now data that's been collected from many people who've been treated with Forteo, not hypoparathyroid people, but there's been no signal of osteosarcoma developing. And in fact, the FDA has removed that black box warning. So I think, you know, it's something that every patient needs to be counseled about, but I think we can feel reassured that all the signals to date are good about that.
I have a question from Phyllis. What impact does hypopara have on joint replacement surgery and healing?
I don't really know the data on that. I mean, one could hypothesize that since bone turnover is low, that it could take longer to heal, because when someone has a joint replaced, we know that the bone building cells need to start laying down what's called the callus, you know, to help the new joint settle in. So it could make sense that the healing would be a little bit delayed in a hypoparathyroid patient, but I'm speculating. I don't know actual data about that.
Okay.
Okay, and then this one is from Kim, and she is asking, has PTH replacement been shown to increase cholesterol and or triglyceride levels given the fat breakdown findings?
That's a really interesting question. Not that I know of, although it could be that there are data that I'm not aware of. You know, the fat breakdown findings, I just want to say are, you know, provocative and interesting, but I think haven't, you know, are only beginning to be thought about. So I wouldn't at all say that we could know for sure that, you know, fat breakdown is happening or not happening in people who are getting PTH therapy. I think it's something to explore. But yeah, looking at the lipids is very interesting, especially because we know hypoparathyroid patients do have an increased cardiovascular risk. So I think that's an important area for investigation.
I have a question from Dasha. Do you study effects on teeth and the jaw?
Um, I think we don't know enough about it. I don't know that there are specific abnormalities that we're concerned about with teeth and the jaw with hypoparathyroidism that are specific to those areas.
Okay.
Okay, and this one is from Karen, and she's asking, how long on that para does it take to more normalize the bone? 17 years post-surgical and 2.5 years on that para. Will my bones ever get to be more normal or always more dense? My alkaline phosphate sometimes goes high and determined from bone.
So we think that the bone starts to become more like euparathyroid bone actually pretty quickly. Already just a few months in, the bone turnover is stimulated. And already 1 year in, the bone density is changing. And, along with that, we think that other aspects of the bone are becoming stronger and more euparathyroid pretty early on. So I think if you've been on Natpara for 2 years or so, that the bone is probably not the same as it was in the hypoparathyroid state. It's very common to have a high ALK phos when you're on parathyroid hormone. ALK phos is one of the markers of bone building activity and bone activation. So I think that's just simply a marker that the Natpara is causing the bone to be stimulated. And I think that's actually very normal and a finding that we see all the time.
Okay, I have a question from Jennifer. What does it mean if osteoporosis was reversed to osteopenia after parathyroid removal surgery?
Yeah, so that can actually happen because when somebody becomes hypoparathyroid, because bone turnover slows down, the bone does become thicker and denser. So somebody who previously had osteoporosis and then became hypoparathyroid can very well move up into osteopenia or even normal bone density. And, that could actually be a protective effect. I think we just don't know. I think it's certainly reassuring when osteoporosis is gone and it's only osteopenia. So that could really be a silver lining of having developed hypoparathyroidism. I think, whether very thick bone is harmful or not, we don't know. I would have to say the weight of the evidence to date is that mostly fractures do not seem to be increased with the thicker hypoparathyroid bone. So I think it probably overall is likely to be protective.
Okay, and then do you recommend collagen supplements for patients with hypopara? And this lady also asked now if you are on, what about if they are on TransCon trial? Is collagen beneficial or other PTH therapies?
I don't really know of robust, rigorous data showing that collagen supplements translate to a beneficial effect. So I think we want, the bone to produce normal collagen, but I don't think that taking a collagen supplement necessarily leads to that.
I have a question here from Phyllis. Are the studies of the effect of hypopara on the body, are there studies on the effect of hypopara on the body and urine pH? And continuing that question, does PTH replacement have an effect on urine and the body pH?
I don't know specifically on pH. You probably already heard during the conference how PTH will lower urinary calcium. It also changes the levels of urinary citrate in a beneficial direction that lowers the risk of forming a kidney stone. So I don't know pH per se, but it does help, in terms of metabolic changes in the urine level.
Thanks. And does anyone, or what else can we do to keep our bones healthy?
Yeah, so I think exercise, you know, whether it's low resistance or high resistance exercise is healthy. And we know that provides a stimulating effect to the bone. You know, of course, having a healthy diet. You know, I think those are really the mainstays. There's, you know, some very recent evidence that maybe high intensity exercise just for general bone health might be more effective than low intensity, but I think that's, you know, just emerging evidence. So I think just being physically active, walking, I think is really probably the best thing one could do.
Okay, and then one more. Given the impact of not having PTH potentially on both bones and kidney function, could this help make an argument for the FDA to help fast track either TransCon or NatPara to help get those back to the market or on the market, or other PTH hormone replacement therapies?
Yeah, you know, I think definitely we need PTH, and not only for the kidney, but likely also for the bone. I think, you know, the case is not as compelling for the bone because we just don't have as much evidence. I think if we had data that in the absence of PTH fractures were happening, and that with PTH it was reducing the fracture risk, that would kind of add to the bone side. But I think it's really unambiguous that having PTH treatment definitely for kidney health and very possibly for bone health is key and would be very relevant to what we would present to the FDA.
Okay, and then one more just came in, and it said it's Timolose, Timolose,
Timolose.
T-Y-N, yeah, an accepted PTH alternative?
Yeah, I think it really can be. I think we just don't know as much about it because so many patients have used Forteo, you know, off-label as a way to help manage their hypoparathyroidism. But Timolose is another form of PTH. It's a form of PTH-related peptide. So it's molecularly a little bit different than Forteo or teriparatide. So we don't know as much. We don't know if it'll yield the same effect to raise calcium as we know teriparatide does. But I think if somebody needs to be on some type of PTH, which is so difficult nowadays to get and cannot get Forteo, I think with careful monitoring from a physician, it would make sense to try Timolose because it would certainly have many of the PTH properties.
Okay, so this is from Phyllis, and it's kind of echoed by a couple other people. It says, based on what you said, can you direct us to literature sources about the effect of hypopara on metabolic changes in urine composition aside from hypocalciuria? And lastly, shout out to Dr. Rubin. She is amazing, both as a physician and as a mentor to her patients. Such an example of patient support that is needed in our area or our care. Thank you, thank you, thank you.
That means so very, very much to me. Thank you. In terms of the urine, that work has been done by Michael Collins and Rachel Gaffney. So I could post a link to their work that shows what I was mentioning.
Okay. Well, thank you so much, Dr. Rubin. It was absolute pleasure having you with us this afternoon.
Absolutely.
And we're gonna, yeah.
We have a,
Any announcements
yes,
from our team?
quick announcement. The survey that we posted earlier, some people were having difficulty, so it's going to go back up again right after we end the seminar with Dr. Rubin. If you already filled it out, you don't have to fill it out again. And then we are going to take a short break and see you back at 1:15 for Dr. Clark.
Awesome. Thank you, everybody. And thank you for those excellent questions.
Thank you so much. Thank you.
Bye.
Bye-bye.